Today's speaker, Dr. Sundar, Professor of Psychiatry, Department of Psychiatry, NIMHANS, Bangalore. And today's moderator, Dr. Nurul Hasan, Dr. Ashwath Babu, Additional Consultant Psychiatrist, Snega Main Care Hospital, Tirunelveli. My dear colleagues, practicing psychiatrists and postgraduates, very good morning to all of you. Indeed, it's a great privilege to organize this All India Evolve PG webinar. I welcome you all this nice Sunday. We are conducting this Evolve webinar on every fourth Sunday. There is a overwhelming response from all over India, and it's very interesting. People are supporting this webinar in a very grand manner. Though it is a postgraduate webinar, it is refreshing for the practicing psychiatrists also. Today we have a very eminent speaker, Dr. Sundar. Dr. Sundar is going to speak about the topic on neurosurgery for psychiatric disorder. Hope this topic will definitely be useful for the postgraduates as well as for the practicing psychiatrists. With this small introduction, and I request Dr. Nurul and Dr. Ashwath to take out this session.
Thank you, sir. Thank you for the introductory note, sir. Very good morning, everybody. Myself, Dr. Ashwath Babu, one of the moderators of today's session. It is a great honor to be part of this Evolve program. It's been more than a year. We are successfully going through this program. I take this opportunity to invite the chairperson of today, Dr. Sujit Sarkar, sir. Sir is currently the Associate Professor of Institute of Psychiatry, Kolkata. He is the editor of Bengal Journal of Psychiatry. He is Associate Editor of Indian Journal of Psychiatry. Sir has more than 60 publications in national and international peer-reviewed journals. Few words about Sir. Sir was very interested and enthusiastic the moment I invited him for the session. He was supposed to be the chairperson for one of the event, as he rightly pointed out few months back. Sir was not able to attend at that time. The fact that he is attending today's event from airport shows his commitment and interest towards academics and the young psychiatrists. Thank you, sir, for being part of the event today. I welcome you to give a short introduction about the topic, sir.
Yes, thank you, Dr. Ashwath. Actually, my thanks are due to the entire team of Evolve, especially the course director, Dr. Panit Selvan. He had told me quite some time back. But this topic is of special interest to me because, we have been interacting quite frequently with the OCD team of NIMHANS, YCJR sir, Dr. Shyam Sundar and others. In fact, we are a part of the OCD consortium also. So basically, this is one area which I feel should be highlighted because previously there was a lot of stigma associated with neurosurgery, primarily because of its so-called quote-unquote irreversible nature. And now with the advent of so-called deep brain stimulation, rather the reversible neurosurgery, what we call it, or minimally invasive neurosurgery, I think there has been a renewed interest in this area, and none other than Dr. Shyam Sundar would be the right person. Rather, he would be the most appropriate person to speak on this because he is a part of the project also, wherein they are recruiting patients and who are undergoing deep brain stimulus, basically resistant OCD patients. So I think we can hear more about it from him, from sir. Other than that, neurosurgical interventions have also been tried for treatment-resistant depression, Tourette's disorder also. But as of now, the significant evidence, rather even in IPS practice, clinical practice guidelines also for treatment refractory cases, neurosurgery, basically deep brain stimulus has been one of the recommendations. Another center which commonly talks about it is a private setup. It's in Jaslok Hospital, Mumbai. Again, Dr. Shamsundar would be telling maybe about it because there was a consensus statement between neurosurgeons and IPS psychiatrists regarding how to go about cases which require neurosurgery, what are the conditions, what would be the indications. So there was a major kind of a conclave with a huge number of psychiatrists and neurosurgeons around 5 years back, and they had brought out certain consensus statements. So there is a lot of renewed interest in this area, especially in relation to treatment-resistant OCD as well as other psychiatric disorders. And I think it is one of the most important topics for PGs, students, everything. In our side, in state hospitals, the biggest problem, again, we have discussed it with Dr. Shyam Sundar, is the rule laid down by the MHCA 27 actually requires that you need permission from state mental health authority before going ahead with any form of neurosurgery, including DBS. So that is a stumbling block because many state mental health authorities properly, including my own state. So this could be one of the stumbling blocks, but I hope we will develop a way for the future so that the patients are not deprived of this effective mode of treatment. With this, I thank once again to the team involved, especially Dr. Panir Selvan and my co-chairs, and over to our esteemed speaker, Dr. Shyam Sundar.
Thank you, Dr. Sujit. Thank you for the kind introduction. So Dr. Sujit has covered a lot about the topic actually. So yeah, it's great to have Dr. Sujit as a chairperson because of his interest in OCD, and he's been working very closely with us. I also like to thank Dr. Panir Selvan and Dr. Nurul, Dr. Ashwath for inviting me for this program.
Good morning, everyone. Before going to the speaker introduction, so briefly, I am informing about the MCQ session at the end of the presentation. So in all the session, we have done this. So a speaker will be asking MCQs in between along the course of the session. Around 3 to 5 questions will be there. The people or residents who are answering the chat box, the first 3 people who answered the correct one in the chat box will be selected for the prize. So we have handed over prizes to all the participants in the last session. And for this session, the question answers will be at the end. So hopefully residents can actively participate in that. Yeah. Dr. Shyam Sundar completed his MBBS from Coimbatore Medical College and MD Psychiatry from All India Institute of Medical Sciences, New Delhi. He worked as a senior resident in AIIMS, New Delhi, and CMS Vellore briefly until he joined as a faculty in NIMHANS. He has completed his fellowship in bipolar disorders from University of British Columbia, Vancouver, Canada. Currently, Dr. Shyam Sundar is a professor of psychiatry at the National Institute of Mental Health and Neurosciences, Bangalore. He is a senior consultant in OCD Specialty Clinic, NIMHANS, Bangalore. His areas of interest include obsessive compulsive disorder, bipolar disorder, RTMS, and electroconvulsive therapy. He has been a part of multiple research projects involving NIBS and deep brain stimulation for OCD. Sir has more than 100 publications, which includes indexed, non-indexed publications and chapters in renowned national and international scientific journals. He is currently the principal investigator in DBT Wellcome Trust sponsored project titled Identification of Biomarkers Predicting the Response to DBS at Subthalamic Nucleus for Treatment Resistance in OCD. After all, Sir is my most respected and lovable professor, and he's one among the primary guides for my both my MD thesis and for my psychotherapy. So we are most honored to have you here in this Evolve forum, sir. Thank you, sir. Thank you. Sir. The dais is yours.
Thank you, Dr. Nurul. Thanks a lot. Somehow it's not. Yeah. So I'll be talking about surgery for neurosurgery for psychiatric disorders. This topic usually earlier it used to be called as psychosurgery, but somehow the term currently is not used that commonly. Now people generally use the term neurosurgery for psychiatric disorders, because there are different types of neurosurgery which I'll be discussing in the subsequent slides. Anyway, just to give a brief history how it started. So as we all know, surgery, when we speak about surgery, people generally speak about like what Dr. Sujit Sarkar was talking about. Psychosurgery or neurosurgery for psychiatric disorder has a stigma attached to it, mainly because when it was started in the 1930s and 60s, when we know about Egas Moniz, the Portuguese psychiatrist who had won the Nobel Prize for that, initiating psychosurgery. Also, even before that, there were other people who had started doing psychosurgery for psychiatric disorders. where they started, like it all based on the theory that based on animal studies, where people found that any damage to the frontal lobe can cause changes to the behavior. The animals, like for example, monkeys which had damage to the frontal lobe became more placid, calmer. So people in asylum, so they started treating people in asylum with sort of lesioning of the frontal lobe. So this started what is known as prefrontal leucotomy or lobotomy. This was especially popularized in the US by Mr. Freeman, Dr. Freeman, and his colleague Watts. And what they did was that they used a very crude procedure. They used this particular instrument. They inserted it through the orbit, and they cut the fibers of the frontal lobe crudely, and they found that it led to changes in behavior. But apart from changes, positive changes, there was also a lot of negative changes that led to a lot of cognitive deficits, personality changes. I think one of the very some famous people also have undergone this surgery and have led to some complications, because of which it fell into disrepute. But later, in the 1940s, I can say 50s to 60s, you would have heard about Jan Telerak, who's the Telerak coordinates which we use in MRI. He was interested in psychiatry. He initiated what is known as the stereotactic neurosurgery for psychiatric disorders. So he devised a system where you can create you can target particular neurosurgical targets in the brain using some special apparatus, and he evolved a stereotactic system for this particular reason, which is being used for various other neurosurgical procedures even now, and it's also used in MRI for finding the location of a particular brain region. So based on this and various other people from Europe, they proposed that there's no need to lesion a large part of the brain. Lesioning of very specific parts of the brain, for example, the anterior limb of the internal capsule, you can see here over here, can lead to improvement in behavior. So they started doing those surgeries, and they started lesioning cingulotomy, which I'll be discussing later. So more focused surgeries, which led to lesser side effects, and better responses were found. And slowly they also found that there are only a particular group of patients who respond to such surgeries. And over the course of time, people understood that primarily people with OCD and depression especially improve with these surgeries. So overall, these surgeries have been primarily practiced in OCD and depression. When this was done, the other thing that changed over time was earlier there was a modular hypothesis of the brain, where people said that particular parts of the brain was responsible for particular behaviors, like frontal lobe, it's for personality, and temporal lobe, it's for memory, something like that. So but later people found that it was not a particular part of the brain, it's a network of brain structures which are connected through circuits. So modulating the brain anywhere in these circuits can lead to behavioral changes. So one of the ways of modulating these brain circuits is deep brain stimulation. So deep brain stimulation evolved primarily with Parkinson's disease, where people started inserting electrodes, very thin electrodes, deep into the brain, and they stimulated subthalamic nucleus. Actually, what happens in deep brain stimulation is they give very high frequency stimulation, which leads to, people say, it disrupts the normal rhythms that are happening in the circuit, which can lead to changes in the functioning of the circuit. So it can create some sort of functional lesion, a temporary lesion in the particular part of the brain. So that was the earlier hypothesis, where people started using DBS for Parkinson's disease. And there are people then from Sweden, they felt that maybe we can use that for other psychiatric disorders also. So they started using deep brain stimulation over the anterior limb of internal capsule for OCD, and they found it to be helpful. The first paper was published in 1999 for OCD, but later, over the past 24 years, lots of papers have been published in various psychiatric disorders, especially OCD, depression, and Tourette syndrome. So yeah, I'll be covering those things. So these are the developments of neurosurgery over the course of time. Of late, people have, there are other newer developments. Basically, people, as I said, people are trying to target particular circuits rather than particular brain regions. And there are other recent advances, which I'll try to cover if there is time. So the contemporary neurosurgical procedures differ from the previous ones primarily because, as I said, they are based on stereotactic and image guidance. So we can place the lesions or electrodes very accurately. And even the lesional procedures, earlier people used to do a burr hole procedure and then do lesions, but right now that is not required. Through gamma knife and focused ultrasound, you can create ablation of a particular part of the brain without craniotomy also. And of course, there is reversible neuromodulation, which includes deep brain stimulation and vagus nerve stimulation. So that is one aspect. The second aspect is careful selection of patients. Earlier, the surgery fell into disrepute mainly because it was used indiscriminately for various indications. But right now, we have understood where it is helpful. And currently, it is only being used for particular conditions only when other treatments don't work. So it is only used for severe chronic and treatment refractory illnesses. And as I said, current surgeries are based on the network model of neuromodulation. We have started understanding the networks underlying various psychiatric disorders. And based on that, we are able to target certain brain regions. And yeah, so this is basically about the network model. This is the current hypothesis of various psychiatric disorders, where it's not one particular part of the brain, it's a network of brain area, generally going from the cortical regions to the subcortical regions. And there are different networks which govern different functional activities. Like some networks are important for motor, some for sensory, some for cognitive functions, some for personality, some for emotions. So you have to find the right network which might be involved in a particular disorder, and we can neuromodulate that particular circuitry through either invasive or non-invasive neuromodulation. This is, for example, the circuits that have been said to be involved in obsessive compulsive disorder, where generally for OCD, we say that there is a circuitry, what is known as the cortico-striato-thalamocortical circuitry, which starts from the cortex, which goes to the striatum, then it goes to the thalamus and goes back to the cortex. So there are different CSTC circuits. Each start from a particular part of the cortex, like say some are from the dorsolateral prefrontal cortex, some from the ventrolateral prefrontal cortex, some from the orbitofrontal cortex. They go to particular regions in the striatum, particular parts of the thalamus, and go back to the same. So these are loops which govern different functions of the brain. So for example, the sensorimotor circuit is responsible for habitual behavior, dorsal cognitive circuit for working memory. Similarly, for some circuits are important for emotional or fear extinction circuitry. So we can modulate these circuits with various treatments. So non-invasive methods, as we all know, RTMS and TDCS are able to non-invasively modulate superficial cortical regions. But unfortunately, we can't reach deep through these non-invasive techniques. So when we want to target deeper regions, we need surgical techniques. So what is the advantage of targeting the deeper regions? So just to give an example, this is the left figure. I think you should see the cursor. This is the anterior limb of frontal capsule. This is the coronal section. This is the dorsal, and this is the most ventral part of the internal capsule. So you can see these are the fibers starting from the dorsolateral prefrontal cortex, go to the most dorsolateral part of the internal capsule, but fibers from the orbitofrontal cortex goes to the most ventral. So we know exactly where, approximately where these fibers are in the internal capsule. So we can target these particular, particular circuits with neurosurgical techniques. So another advantage of this thing is that, as you can see in the right figure, although we say that these loops are segregated, but there is a lot of crosstalk between these circuits at the level of the subcortical structures, say in the subthalamic nucleus, or even in the caudate and other subcortical structures. There is a lot of crosstalk. So when you stimulate these deeper structures, you will be able to modulate multiple circuits rather than the single circuit, which we can be modulated through the superficial neuromodulation. So these are called the hub regions, because of which, where the surgical treatments are targeted. So like Dr. Sujit Circle was saying, 4 to 5 years back, we had a meeting in Mumbai where we formulated a guidelines for neurosurgical treatment for psychiatric disorders. And the consensus guidelines includes the following. This is very much in line with the international guidelines. All the guidelines say that the indications for neurosurgery is severe chronic and treatment refractory OCD, depression, and Tourette syndrome, because the evidence is best for these indications. And apart from that, there are a few other things in the sense that that is required for it requires a multidisciplinary team, because with neurosurgery team who has expertise in functional neurosurgery, and generally these procedures take some time to work. Usually improvement happens over months to sometimes it may take up to 1 year. So it requires regular follow-up by a multidisciplinary team. Yeah, and of course informed consent has to be taken from all patients. So it is not the patient themselves have to consent for this procedure. Only then the surgery can be performed. As I said, there is international guideline. They also are very much in line with it. They say that it has to be given for the same indications. But another important thing is that the neurosurgery is not a standalone treatment. It is not a cure for psychiatric disorders. Yeah, many patients come and ask us whether I can stop medicines after that. I can just cure my OCD once for all with surgery. But that doesn't happen, because surgery is just an augmentation treatment for treatment refractory people. Along with it, other treatments have to be continued even after surgery. Yeah. So what does the Mental Health Care Act say? This was also covered by Dr. Sujit Circle. Mental Health Care Act says that surgery can be done under two conditions. Informed consent of the person has to be taken, and there's a required, we have to get approval from the Mental Health Review Board for surgery. So each patient who has to undergo surgery, we have to submit an application to the Mental Health Review Board along with the informed consent form, and the review board has to approve the surgery. This has been a roadblock in many places because Mental Health Review Board has not been constituted in many states. So yeah, with this we'll come to the topic per se, that is neurosurgery. When we say about neurosurgery, there are four major surgeries. One is ablative surgery, where we create lesions, DBS, and there is vagus nerve stimulation, and there is also epidural cortical stimulation, where you stimulate the cortical regions with intracortical epidural implants. But the later two are generally that commonly practiced. So I'll be primarily focusing on ablative and DBS. So coming to ablative procedures, yeah, you would see in textbooks there are four procedures that are commonly discussed. One is the anterior capsulotomy. Anterior capsulotomy, you create lesions in the anterior limb of the internal capsule. So you go anterior because you want to save the motor fibers which are in the genu and the posterior limb. So you go to the anterior limb, because in the anterior limb, the frontostriatal fibers, the fibers from the frontal cortex to the basal ganglia are traveling through that, which is involved in behavioral and cognitive process. So you create lesions over there. That this surgery is commonly used for treatment of OCD. The second is anterior cingulotomy, where you create lesions in the dorsal anterior cingulate and the adjoining white matter structure, which is cingulum bundle. So this particular part of the brain has been important for cognitive as well as emotional control. And people have found that this is helpful in the treatment of major depressive disorder. So these are the two main lesional surgeries that are practiced. But some people do what is known as subcaudate tractotomy. This is not commonly practiced now, where you create lesions in the ventral to the caudate nucleus. So they say that just below it, these are white matter fibers. And this has also been tried for both OCD and depression. But generally, it's not done as a standalone procedure. Rather, it is done along with anterior cingulotomy, which is known as limbic leucotomy. So people, like some people, do anterior cingulotomy, and if the person doesn't respond, they add subcaudate tractotomy for resistant patients. So as I said, anterior capsulotomy is the most commonly used procedure for OCD. Earlier procedures used to be performed with what is known as thermocoagulation or radiofrequency ablation, where you insert probes into the brain and create lesions. But right now, the most common procedure, what is known as gamma knife surgery. As we all know, this is a helmet-shaped structure where the person goes inside. Multiple gamma rays are targeted to a particular part of the brain. So each gamma rays by themselves are not very strong, so they don't create lesions in the pathway. But when they strike on a particular target, they create lesions in a particular part of the brain. So the advantage of gamma knife surgery, it's there is no need to open the skull at all. So yeah, a person goes into the surgery and comes back having a lesion. The person himself doesn't know whether the person has undergone a surgery. A more recent advanced technique is known as magnetic resonance guided focus ultrasound, where you use ultrasonic waves similar to gamma rays to create lesions. And it is done under the guidance of magnetic resonance. So you can see the lesions being created live. So this is a new procedure. It's generally used for fibroids and other gynecological surgeries, but recently people started using it for capsulotomy also. So this is the target, as I said earlier, this is the target of gamma knife. So this is the coronal section, if you can see, of the internal capsule. This is the dorsal most part and this is the ventral most part. Over the course of time, people have recognized that lesioning, creating the lesion more ventral has better response in OCD. So this is the gamma knife target of one of our patients, the middle figure. So this is the internal capsule, and you can see that this is the lesion. The yellow ring is the lesion where we are targeting the lesion. So the more ventral, the better the response. And this is the axial section. So this is anterior. The upper part is the anterior. The lower part is the posterior. You can see this is the genu of the corpus callosum. So you go 8 to 10 millimeters anterior to the genu, anterior to the anterior commission. So this is where the lesion is produced for internal capsulotomy. Yeah. So this is based on our experience. We have done anterior capsulotomy for 8 patients. 4 patients had response and 2 patients had partial response. Side effects were very minimal. 1 patient developed 1 seizure, and after that the person is doing well even now. So there are no deficits in neuropsychological testing or in personality changes in any of these subjects. So this is an overall review of all different procedures that have been used for lesional procedures that have been used for OCD. As you can see, capsulotomy and cingulotomy have better response. But in terms of reduction of iBox score, capsulotomy has better response. So capsulotomy remains the preferred procedure for OCD. As I said, cingulotomy, you create lesions in the anterior limb of the internal dorsal anterior cingulate cortex. This is primarily practiced in one particular hospital in the US, Massachusetts General Hospital. And yeah, they have done more than 1,000 surgeries right now. And they say that like the side effects are very minimal. And yeah, and one of the things is that what they do is, like, if the one surgery doesn't cause improvement, they do repeat lesions in the either in the anterior cingulate or subcaudate tractotomy, and they have found a response rate up to 75% in patients with depression and also in OCD. We have done in 2 subjects anterior cingulotomy. We used to do it before capsulotomy. Once patient improved, the other person didn't improve. So yeah. Yeah, I think this I have discussed already. Subcaudate tractotomy, where we create lesions in the just ventral to the caudate nucleus, and that is generally not used as standalone procedure. It can be used as an add-on procedure when the anterior cingulotomy is not effective. Anterior capsulotomy, as I said, is more commonly used for OCD, but it has also been tried in depression, and people have found around 50% improvement. But generally, the trend is that if you want to create lesions, you create in the anterior limb of internal capsule for OCD and anterior cingulate, dorsal anterior cingulate for depression. So what are the adverse effects of this procedure? So these are adverse effects based on older procedure. Actually, the adverse effects have become have decreased over time, because over time we have learned a lot where to create the lesion with minimum side effects, and the surgical techniques have also improved. So currently we can say the chances of adverse effects is less than 1 to 2%. So earlier, when open surgeries used to be done, there used to be things like headache, delirium, CNS infection, hemorrhage. But those things are rare because currently most of the surgeries are done with gamma knife. But still, since we are using gamma knife, radiation necrosis can happen. Long-term side effects, personality changes have been reported because we are lesioning the frontal circuitry. So personality changes can happen. Cognitive deficits, especially executive function deficits, can happen because of the same reason. And seizures, incontinence, weight gain, these are all side effects that are possible. The chances are 1 to 5%. Okay, with this now, I'll come to deep brain stimulation. So what is deep brain stimulation? As we discussed earlier, deep brain stimulation is an electrode that is inserted into a particular part of the brain, which is connected through a wire to a battery. The battery is placed generally below the clavicle, subclavicular region in the subcutaneous tissue. And through that battery, we give chronic stimulation to a particular part of the brain. It's just like a pacemaker. Yeah, the advantage with deep brain stimulation over surgery is that it is reversible because we can switch off the battery and we can optimize the stimulation parameters. How does it work? There are various theories that have been postulated, but generally the theory is that, as I said, all these surgeries are targeting different networks. The different networks are communicating in a particular rhythm. Say they may be communicating with gamma rhythm or beta rhythm, what we study in EEG. And this DBS sort of modulates that particular rhythm because it modulates the dysfunctional rhythm to a more physiological level. So what are the advantages and disadvantages? As I said, it is a reversible neuromodulation. You can switch on and off the battery, because of which the side effects can be reversible, and stimulation is adjustable. Like, for example, if like you give a low stimulation, if there's no improvement, you can give a higher stimulation. And if there is higher stimulation, there is side effects, you can give a lower stimulation. So these things are possible. And another major advantage for research purposes is that sham stimulation is possible. You can insert the battery, the person doesn't know whether the stimulation is on or not. So you can compare when the stimulation is on, when the stimulation is off, to see whether there is any difference in a randomized controlled trial. The disadvantage is that it is more expensive. The device is more expensive, and you may have to replace the batteries periodically. But of late, there are rechargeable batteries which can be recharged. So this cost has decreased, and it requires a highly skilled interdisciplinary team with frequent monitoring, because it requires programming and other things. And it requires burr-hole craniotomy. A small burr-hole surgery has to be done to insert the electrodes. So this is how we prepare a patient for surgery. At NIMHANS, basically we do a clinical examination to confirm the diagnosis, treatment refractoriness, and then we do an MRI to rule out any other neurological lesions. And also it would be helpful for planning for surgery. We do a detailed neuropsychological evaluation, primarily focusing on the frontal lobe functions and frontal lobe behaviors to see if there is any changes following surgery. And after that, this is very important. In NIMHANS, we have an independent committee of psychiatrists, neurologists, and neurosurgeons who screen all our patients who undergo surgery. They are not attached to NIMHANS. Only if they give permission, we go ahead with the surgery. But of late, we are also getting permission from the Mental Health Review Board for proceeding with the surgery. So DBS consists of three steps. One is insertion of electrodes, where this is the electrodes. The right side, you can see this figure is the electrodes. You can see that the electrode has multiple contacts. The silver colored things are the contacts. Any of these contacts can be kept on and the others can be kept off. So that is the advantage with DBS. So once you insert the electrodes, you stimulate one contact and see. And if that leads to side effects, you can stimulate the other contact. So there is some flexibility with respect to the stimulation. So so insert this collector, this contact with help of image. So this figure, middle figure, if you can see, this is the surgery for one of a patient with OCD, where we targeted the subthalamic nucleus. So the anteromedial part of the subthalamic nucleus. You can see the green, the yellow color line is the trajectory for where we will be planning to insert the electrodes. So through image guidance, we insert the electrodes, and this is connected to a battery. This is the battery, the middle one, which is connected to the electrode through a small wire that runs subcutaneously. So there are two types of batteries, as I said, non-rechargeable, which has to be replaced every 5 to 6 years, or rechargeable batteries, which the person himself or herself can charge. And the third step is what is known as programming, where you modulate the program in different ways. Say there are different things that can be modulated. You can modulate the frequency, pulse width, amplitude, and you can change the different contacts and see, and you can see which is leading to the best improvement, and we can maintain that for long-term treatment. So generally, to identify the best stimulation parameters, it may take some time. It may take 3 to 6 months. Yeah, it may take up to 12 months also. But what has been seen in psychiatric disorders is generally it takes at least a few months for the improvement to happen. So chronic stimulation is required. Unlike in many movement disorders where the improvement might be seen immediately, in psychiatric disorders, at least 1 to 2 months are required for the person to notice improvement. What are the adverse effects? The adverse effects are, it's an open surgery, cerebral hemorrhage infection, which are very, very rare considering the recent advances. device-related device breakage, device-related depletion of battery. These are also relatively rare side effects, but depletion of battery is an important thing. Many patients with OCD and depression, it has been reported in the literature that suddenly when the battery depletes, they have an acute worsening of symptoms, and the battery has to be replaced immediately. There might be like people have developed severe suicidal ideations when the battery depletes also because of the relapse of depression. So yeah, there are other side effects because sometimes if you stimulate the nearby motor pathways, you can develop some dysarthrias and dyskinesias. And some mania is a common side effect because many of these circuits have an effect on the reward pathway and the mood. So some of these circuits can lead to mania. But all of these side effects, stimulation-related side effects, are reversible. You can just change the contact, or you can change the stimulation parameters to yeah. So with this, I'll be going to the evidence. What is the evidence for DBS in OCD? This is the selection criteria. This is based on the IPS guidelines. So basically, it's the same. I think you can go through the IPS guideline. Basically, patients should have severe OCD with a Vivox about 28, at least 5 years of illness, and like patient who has not responded to at least 2 SSRIs, clomipramine, 2 augmentation, CBD trial. Only after these criteria are met, we go for this patient can be considered for surgery. So these are the DBS targets that are commonly used in OCD. There are 7 targets I have mentioned here, but I'll be discussing 2 primary targets. One is the ventral capsule, ventral striatum, and another is the subthalamic nucleus, because these are the commonly used targets for OCD. So this ventral capsule, ventral striatum, when we say ventral capsule, it is the ventral part of the internal capsule. Ventral striatum is a region that is the nucleus accumbens that is just ventral to the internal capsule. So nucleus accumbens is an important region of this reward pathway. And initially DBS, when people started using DBS for OCD, they stimulated the internal capsule. And they found that the stimulation of the inferior or the ventral nucleus accumbens also led to improvement. So people felt that maybe that also can be a separate target. And slightly anterior to the nucleus accumbens is the region known as the bed nucleus of stria terminalis, which is important for anxiety. So stimulating that region also led to improvement in OCD. So right now, what people do is they insert an electrode which has some contacts in the internal capsule and some contacts in the ventral striatum. So that is why it's called the ventral capsule, ventral striatum. You can see stimulating which part of the brain leads to improvement in a particular patient. Based on that, you can modulate the stimulation in a particular patient. So this is a very commonly used target for OCD. So there are many studies. I'll just show one study where a patient cohort of 70 patients, they gave DBS of the internal capsule. And they found that 50% of the patient improved and 17% of the patient had partial response. So, but one disadvantage of this particular target is that the battery gets over very fast. Generally in other targets, the battery lasts for 5 to 6 years. Here, on 1.5 to 2 years, the battery has to be replaced. So that is the advantage of the next target, which is the subthalamic nucleus. The subthalamic nucleus, you can see the right, this figure is divided into 3 regions. One is the motor part, and the middle one is the associative or cognitive part, and the most ventral one is the limbic part, which is important in emotional function. So the motor DBS part of the subthalamic nucleus is targeted for treatment of Parkinson's disease, but the limbic and associative, the junction between the limbic and associative is the target for OCD. So this was tested by Luc Mallet and colleagues from France. This is a randomized control trial. The patient was not aware of it. They kept the stimulation on for 3 months and off for 3 months. So you can see this figure. When the stimulation was on, the Vibox score decreased, and when it was off, the Vibox score increased. So patient was not aware of it. So this was a randomized control trial based on which it was clearly established that DBS is effective in OCD. So we have collaborated with this particular group, Luc Mallet, and we have started this particular project where we are trying to find the predictors of improvement for subthalamic nucleus DBS in OCD. So basically, this is funded by the Wellcome DBT, and all the surgical process and everything is funded by the project. So it's free for the patient. So if there is any patient whom you feel that her treatment refractory, you can refer to the OCD clinic NIMHANS for this surgery. Yeah, this is the DBS, what we are experienced till date. We have done DBS in 7 patients till date over the subthalamic nucleus, and 5 of the 7 patients had respond to treatment. And these are patients who are not responded to any other treatment, including medications, pharmacotherapy, and psychotherapy. We did see some patients who had hypomania and dyskinesias, but all of these things were reversed after optimization of stimulation parameters, and no long-term side effects were noticed in any of these patients. Okay, I think the same slide is there. So this is just a small video to show the location of the electrode in the subthalamic nucleus. You can see the yellow part is the limbic part or emotional part, and the blue part is the cognitive part. And this is from one of our patients. You can see the target is between the limbic and the cognitive part of the subthalamic nucleus. So this patient had responded very well to treatment. Okay, so as I said, there are 2 targets, the subthalamic nucleus and the ventral capsule, ventral striatum. There is a study, an UK-based study, which compared these 2 targets in the same patient. So in the same patient, they they did DBS for subthalamic nucleus for some time, for 3 months, and they did DBS over ventral capsule, ventral striatum for 3 months. And they found that both are equally effective. So both, there was no significant difference between, so both are equally effective. But the difference was ventral capsule, ventral striatum was more helpful in depressive symptoms, whereas subthalamic nucleus was more helpful for cognitive dysfunction. So based on this, people have found that there are different targets for DBS, but all are effective. So people have tried to find out, they did collected the MRI of all patients who have undergone DBS, and they tried to see if there is any particular pathway or the neural pathway which is targeted by all these successful surgeries. So you can see the figure in the left. The red one is the successful pathway. So DBS over successful pathway targets the red color circuitry, which is a pathway that runs from the anterior cingulate to the subthalamic nucleus. So right now, people are saying that this is probably the OCD pathway, and targeting in this pathway might be helpful. So this is again a small video of one of our patients where you can see the red color pathway. This is a patient who responded very well, and the red color pathway was stimulated in this particular patient, and the patient had good response to treatment, which runs from the dorsal anterior cingulate to the subthalamic nucleus. Anyway, this is just a meta-analysis to combining all the studies done in DBS till date. Generally, at last follow-up, you can see 66% were responders, and patients had improvement in depressive symptoms too. So generally, the evidence has been quite consistent for OCD. That's why Dr. Sujit Sarkar was saying OCD is one of the main indications where for psychosurgery as of now. And long-term studies have been done, and they have shown response up to 75%. Most of the patients had no major long-term side effects. And another important thing, CBT may augment the effect of DBS. Like people who have not responded to CBT in the past, after DBS, they respond to CBT. So now we'll come to the next disorder, that is major depressive disorder. The criteria for major depressive disorder is also very similar, where the person should have severe depression and poor functioning, and should not have responded to antidepressants, multiple antidepressants, CBT, psychotherapy, ECT, and only then we select them for surgery. So the targets for depression are slightly different. One of the important target is the subcallosal cingulate cortex. We discussed that when we create lesions, we create in the anterior, dorsal anterior cingulate. This is the corpus callosum. I think you can see the cursor. Just above the dorsal to that is the dorsal anterior cingulate, where we create lesions. But for DBS, the target is subcallosal cingulate. This is below the corpus callosum. The cingulate part of the cingulate, this is the cingulate cortex, a part of the corpus callosum. Below the corpus callosum is the region. So this is based on neuroimaging evidence. A series of studies done by Helen Mayberg and colleagues from USA, they found that this particular part of the brain is hyperactive in people with major depressive disorder, and even when people are in normal sadness, like they invoke sadness in people and they did an imaging, and they found that this particular region lights up. And interestingly, many studies have found that after treatment with antidepressant, CBT and RTMS, this hyperactivity decreases. So maybe whether we can directly inhibit this particular region through this deep brain stimulation, that was the reason people started targeting the subcallosal cingulate. The second thing is the ventral capsule, ventral striatum, the same target that we have people have targeted in OCD. This was used mainly because people found that along with OCD, depression also improved. So why not use it in depression also? So they found that, and it was also another target. The third target is what is known as the medial forebrain bundle, which is a bundle that is going from the ventral tegmental area to the orbitofrontal cortex. It's important, the reward pathway. So this is another target. So the difference, you can see the difference between the cingulate cortex, which is important in sadness, whereas medial forebrain bundle is more the reward pathway. So theoretically, we can say that the subcallosal cingulate improves sadness and medial forebrain bundle improves the mood, rather than decreasing the, so like, for example, for things like amotivation sort of symptoms, this particular pathway might be more beneficial. Another target is what is known as inferior thalamic peduncle, which is connects the orbitofrontal to the thalamus thing. So, but most of the studies have been done in these two regions, subcallosal cingulate and the ventral capsule, ventral striatum. So this is just another meta-analysis which has shown that DBS overall has been found to have good response in depressive disorder. All was going well till these two studies were published a few years back. These are two large randomized controlled trials where they compared active to sham stimulation, one in the subcallosal cingulate and the ventral capsule, ventral striatum. And these two industry-sponsored studies, they did an interim analysis. That is, early in the course of the study, they tried to interpret the study, and they did an analysis to see whether there is any trend in improvement or not. Both the studies found that there was no difference between the active and sham arm. So both the studies were stopped by the investigators. And after this, there was a lot of discussion whether DBS really works in depression or not because of these two negative studies. But later, people found that there could be other reasons for the non-response in these two studies. As I said, mostly in surgery for depressive disorders and OCD, the improvement takes some time to occur. These people did not, in the sense that the stimulation parameters has to be adjusted to find the right balance for a particular patient. So these two studies did not allow this particular thing to happen. So probably that might be one of the reasons. So there have been some recent studies which have had longer optimization periods, and they have shown some positive responses. And also improved targeting. So people have found, based on a particular fiber pathway, they have tried to target a particular region, and with this, the improvement has been better. So again, for the past 2 to 3 years, there has been again a resurgence of interest of DBS in depression after these studies. So overall, in depression, it is the subcallosal cingulate or ventral capsule, ventral striatum. That is the target. Now coming to Tourette syndrome, I'll briefly talk about it. I'll not take much time. There are 3 main targets in Tourette syndrome. One is thalamus target, another is globus pallidus, and another is anterior limbofungal capsule and nucleus accumbens. That is the same thing, ventral capsule, ventral striatum. So overall, studies have found that 53% of patients reduction in the tic severity scale, and yeah, it has been found to be helpful. Generally, in Tourette syndrome, it is only given for people for whom Tourette's is refractory to standard medical and psychological treatments, and also the tics should be present long enough and severe enough. So we have done DBS for 2 Tourette syndrome at NIMHANS. Both the patients we targeted the globus pallidus. You can see the graph, the tics decreased over the course of time. The second patient was more dramatic. It's a 14-year-old person who had central injury tics. He had he used to hit his eye, and he had loss of vision in one eye. He started hitting the second eye. So when that's when the family members felt that they need to go do something more radical. So we had to get permission, and we started perform DBS for this particular patient. And we found that you can see this figure where the tic severity decreased, and the patient is doing well even now. It's been about a year right now. And the patient had concomitant OCD, and the OCD also had improved over time. Okay, so I'll briefly talk about vagus nerve stimulation. Vagus nerve stimulation is not very commonly used nowadays. Vagus nerve stimulation, you insert electrodes around the vagus nerve, and similarly, it's connected to a battery. The mechanism of action is that probably from the vagus nerve, it goes to the brain, and it has connections to the various parts of the brain, and through that, it can stimulate the brain indirectly. So it was initially tried for depression, for epilepsy, but people found that people with concomitant depression also improved in these patients. So people started using it. Anyway, there are very few studies available. The acute treatment studies have not been very encouraging. They didn't find any difference between the active and sham group, but long-term studies have found some improvement. So overall, but the improvement rate with vagus nerve stimulation is much lower than DBS. So it's not very commonly practiced nowadays. There are some adverse effects, because it stimulates the vagus nerve, it can vagus nerve related side effects like vocal cord paresis, hoarseness, and sort of things can happen. So this is my last slide. To summarize, ablative surgeries and DBS have a role in carefully selected patients with treatment refractory severe OCD, depression, and Tourette syndrome. Of late, there is emerging evidence for anorexia nervosa and substance dependence also. Among the ablative surgery, you choose capsulotomy for OCD and cingulotomy for depression. The advantage with ablative surgery, it's an irreversible procedure. It's a one-time procedure. It's less expensive, but the irreversibility is the disadvantage also, because if the person develops side effects, you can't reverse it. DBS, it's a flexible stimulation, but it needs more closer follow-up. Generally, recent surgeries or recent studies have shown that 60 to 70% of patients improve with this procedure. One important thing is that it's not a standalone treatment, and it should be considered to be one of the treatment modalities in a comprehensive package, which includes medications and psychotherapy also. Thank you.
So thank you for the crystal clear and a very lucid presentation, sir. So we are going to the MCQ session. We have 5 questions today. So the first 2 people who are answering in the chat box will be taken up for the prizes. So here is your first question. So the following is the preferred ablative neurosurgery for OCD: palidotomy, anterior capsulotomy, anterior thalamotomy, and limbic leucotomy. Yes, we have many responses in the chat box. I think I will go with the second one.
Can you give the answers?
Yes, sir. The answer is B, anterior capsulotomy. And the following is a deep brain stimulation target for depressive disorders. Option A, anteromedian subthalamic nucleus, globus pallidus interna, subcallosal cingulate cortex, and option D, orbitofrontal cortex. Okay, so we have many responses. The correct answer is option C, subcallosal cingulate. I'll go with the third one. Deep brain stimulation has been found to be helpful for the following condition: Tourette syndrome, body dysmorphic disorder, trichotillomania, hypochondriasis. Yeah, great response. The option A is the correct answer. That is Tourette syndrome. Fourth question. The following is true regarding deep brain stimulation for OCD. Improvement is expected immediately after surgery. SSRIs can be stopped 3 months after surgery. Does not require craniotomy. Stimulation-related side effects are reversible. Yeah, many correct answers. And option D, stimulation-related side effects are reversible. That is the correct answer. The last question. Pre-surgical planning for psychosurgery includes the following except: written informed consent from the patient, permission from the Mental Health Review Board, CT scan of the brain for surgical planning, and detailed evaluation to confirm the patient has severe chronic and treatment refractory illness. If we have many correct responses, the answer is C. CT scan of the brain for surgical planning. Thank you. Thank you. Those are the correct answers. Yes, sir. Now the forum is open for Q&A. So I will start with my question. So the first question, for neuromodulation, through the non-invasive mode, we are targeting the more of the cortical level, surface level positions. But when it goes to invasive brain stimulation, we are going into a deeper area. So though we do understand the concept of the connectome crosstalk and all, so we can't be think of the same with the cortical level. So this is my first question, sir. And the second one, can you briefly talk about the cost of deep brain stimulation? So to set up a DBS suit, because through your experience and from the international experience, there are almost fair amount of improvement happening with the DBS. That's the case. So how much do we need to set up a DBS suit?
Thank you, Dr. Rourette. So regarding the first question, yeah, so you're asking whether invasive stimulation can be used for cortical regions. Is that your question? Yeah.
Yes.
So people have started using it also. A few people have started using it. That is called as epidural cortical stimulation. But the thing is that when RTMS, when non-invasive stimulation can modulate the cortical pathways, why do you need an invasive procedure? The advantage of the invasive procedure is that, like for example, the RTMS or TDCS, it's not continuous stimulation. You just give it for a few hours, like 15 to 20 minutes every day. It's not a continuous stimulation. For if you need continuous stimulation, maybe such continuous cortical stimulation can be possible. So some people have started studying. But the issue is that apart from the crosstalk happening in the subcortical regions, the other advantage is that in subcortical regions, all the fibers are quite condensed in a particular part of the brain. So it will be easy to target in those regions than the cortical regions. Okay. That is the advantage. So regarding the second question, how much, DBS suite and sort of things, it's difficult to talk in those things because DBS is a multidisciplinary procedure. It requires a neurosurgeon. So it with experience in DBS, and it's quite expensive in the sense for the patient who undergoes surgery, say like in a private hospital, like what Dr. Sujit was saying, it will cost around 10 lakhs for a patient, for the 10 to 15 lakhs. If there are cheaper versions available where we use non-rechargeable batteries, where 6 to 7 lakhs, it is possible. But generally 10 to 15 lakhs is the cost in private hospitals for DBS for the patient. It requires a lot of setups, like for the targeting, you need separate apparatus, those sort of things. It requires a proper neurosurgical apparatus and team to do it. So
So regarding the, how long do we need to wait for the improvement to happen, sir? Because we need to psychoeducate.
Generally, people have said that it can take up to 1 year, 6 months to 1 year. But what we have seen is generally within the initial 3 to 6 months, we start noticing the improvement.
Okay, this is my last question, sir. Regarding the MHRB. So as we all know, so we do have issues in the private setup for getting a permission for ECT or ECT in children and for non-consenting patients. Even for ECT, this becomes a major issue. So if this neurosurgery comes into the spectrum of treatment of psychiatric illness, so how do we take this? So getting a consent from MHRB, because they are already anxious from the judge side or other member side. There are some discussion happening in the other psychiatric forum in the Tamil Nadu. So if someone applies for a ECT for a child around 16 years, they at least take, for example, Madurai or Coimbatore, they at least take some kind of 4 to 6 weeks or at least 1 month. So even for ECT. So when it comes to brain stimulation or ablative surgeries, it will take much more, considering the stigma or kind of preoccupation about the complications. So how do we take this, sir?
Yeah, this is a challenge which we are also facing because not everybody in the MHRB are familiar because it's people are like even non-medical people are involved in the decision making. So that's what the issue is. I think we should have a discussion with them, explain to them. Like for example, with Maharashtra had a similar issue. So they had constituted a panel to give them advice, and I was part of the panel. I had to, so we had a discussion regarding the procedure and how to go about it. And after that, things are running a bit more smoothly over there. So it's better to have a discussion with them and explain the thing. Especially ECT in children, it's a major issue because it's an acute treatment. Yeah.
Yes, I think compared to the institute side, delivering ECT to the child of 53 is actually very high in the private setup. So the private side, there's so much of difficulties compared to the government setup or that.
Yeah.
Yes, and the question, any question from the other participants?
Dr. Shyam Sundar, have you tried for any invasive brain stimulation for the people with resistant depression at NIMHANS other than OCD?
So one patient we have tried cingulotomy. Yeah. Apart from that, we have not done for any other patient till date.
Resistant depression, anything?
Only once. One patient with cingulotomy for depression.
Oh, what was the response?
The response was good. The patient developed some side effects actually after that, some personality changes because we did a ablational procedure. So we are planning, like there are other patients. So now we are planning to go towards deep brain stimulation hereafter because of this thing. Yeah.
How long the patient has to stay in the hospital, for example, OCD or a cingulotomy, capsulotomy? Inpatient.
Yes. Inpatient stay. Actually, cingulotomy and capsulotomy are very simple procedures. They can just come within 2 or 3 days. The patient can leave also. But for deep brain stimulation, the patient has to stay a bit longer because it has an ablative procedure, like it's an open surgery. Post-operative care is required, and the patient needs some programming. So deep brain stimulation may take about a month of IP care.
After the surgical procedure for OCD, resistant OCD, they have to continue medication or only this surgical or this?
No, so they have to continue medications. Many of our patients also who have not been responders to medications before surgery have been responders after surgery. And when they stop the medicine, sometimes the symptoms relapse. So we advise people to continue the medication.
The same dosage?
At the same dosage. We generally don't decrease it. Maybe when there are multiple augmenting agents, we try to take that away and keep them on a single SSRI. We generally decrease it to one SSRI and continue them on.
Any other questions from the audience? Chat box, Nurul?
Somebody has asked about the scope of closed loop neuromodulation in OCD. Yeah, that's an interesting question. I think Saurabh has asked. It's from NIMHANS. Anyway, so the thing is, closed loop neuromodulation is one in which rather than giving continuous stimulation to the brain, you pick some signals from the brain, and only when the signal is above a particular threshold, you give stimulation. So this has been tried in Parkinson's disease, where they found that when the beta rhythm in the subthalamic nucleus is about a particular thing, they can modulate only during that period, then you can give a stimulation. So that has been tried. In OCD, such things have not yet been found, but people are studying it. We are also studying it. We are also trying to try to find the rhythms of the subthalamic nucleus which are associated with OCD. But as of now, there is no, we don't have any immediate implications, but that is something that might develop in the future. So the side effects might decrease, and the battery also might last longer. That is an advantage with closed loop stimulation.
Okay. So other question is neurosurgical treatment for people with severe substance use addiction.
Substance addiction. Yeah, there are studies going on. As we were discussing, nucleic accumbens and the reward pathway is a commonly targeted region for in DBS. So people have started studying it, and they have found some encouraging response, both for addictive disorders, and I also talked about anorexia nervosa. And sometimes these targets are used also for obesity. Also, people are studying it. So they have found some encouraging response in these 3 disorders.
Okay.
I think there is somebody who's asked about any psychotic spectrum disorders. Yeah, as of now, actually, there is only one study I can say which have studied DBS for schizophrenia, treatment-resistant schizophrenia. They have also targeted the subgenual anterior cingulate for some reason, but apart from that, there is not much evidence. So as of now, there is no clear-cut evidence for psychotic disorders.
Okay, so coming to that, the closed loop kind of discussion. For
Yeah.
example, sir, is there any idea or experience about, so we are doing a ablative surgery or a DBS for one patient, so he has not improved adequately. The same patient is followed with the NABS, for example, RTMS or TDCS. So is there any experience like that? Because that the first one creates already a signature in the brain, and the second one can further augment. That makes a
Yeah. That's a very interesting question, actually. The one thing is that, especially after deep brain stimulation, because there's a metal in the brain, RTMS should be avoided because we are giving magnetic stimulation. That is very important. But TDCS and sort of things can be provided. There is not much evidence, but it is possible because one, you target the subcortical structures with the DBS, and then you give the cortical stimulation for RTM with TDCS or something. So that is something interesting. People are looking into it, but no studies are available as yet.
Okay, thank you, sir. About ECT, sir, neuroablation or DBS, and the patient is worsening in the later period of.
Yeah. People have given it. ECT, again, you had to be a bit careful before, after DBS especially. But people have given it successfully in people who have relapsed with depression, and they were able to give it for some patients with some precautions, and they were able to do it.
There's one question, sir, for neurosurgery for depression, which symptom domain have the improvement most?
Okay, yeah, it depends on the thing. That's why I said the subcallosal cingulate is a region that is important. Let us modulate sadness. So when there is extreme low mood in subcallosal cingulate, low mood seems to improves. But the medial forebrain bundle is a part of the reward pathway. So stimulating those regions improves things like psychomotor activity, increased energy, and sort of thing. So this is something people have observed, but it's not been studied in a case control study or something like that. But this is something that has been observed, randomized control trial or something like that. Yeah, people have observed it. So it depends. Okay. But in subcallosal cingulate, sadness is something that improves. That has been routinely found.
Thank you, sir.
Somebody has asked about the long-term benefits. People have continued DBS for 10 years, 15 years also, and they have found that it maintains the improvement.
Yeah. Okay. Sir, a family member of the patient is ready for the option of neurosurgery. So comparing the gamma knife with DBS, so how do we explain the patient about the risk benefit? That is another question in the chat box.
Okay. Yeah, DBS versus capsulotomy. Yeah, so we discussed with the patient that for some patients, capsulotomy seems to be a simple procedure because it's a one-time procedure. But we explained to them that it's an irreversible procedure, and DBS has that advantage where things can be reversible. Of late, generally the field is moving more towards DBS because of the reversible nature. And when we discuss with our patients also, patients are slightly preferring DBS mainly for this particular reason. Because if some side effects happen, it can be reversed. But it's basically we discuss everything to the patient and let the patient take a call. DBS is more expensive, so some patients do say that we'll better try with capsulotomy if there's less side effects. Yeah.
So once the electrode is implanted, so whether will that be there for lifelong, or we can take up in the future?
Even in patients who don't improve, many people don't take the electrode because why to meddle with do another surgery when it is not required? Why to? You just can leave it as such. It doesn't cause any major issues. So it can be there throughout. It should not cause any major issues.
So any studies on neurocognition improvement through DBS?
Yeah. People have found neurocognition actually improves in a few patients with DBS. Yeah. Okay. There are studies which have found that neurocognition improves. Both in OCD, primarily in OCD, there are some studies.
Yes, sir. Bunny sir, if there are no more questions, then we can plan the conclusive remarks, sir.
Yeah, we can ask Dr. Sujit to conclude, to give his remark.
Yeah, I
Sir.
think I think it was really an enriching session because almost all the aspects were asked, and I think we all have been enriched with this. And I must say that it is definitely a promising option. However, the cost remains an issue, and sometimes it seems that ablative neurosurgery isn't that bad an option compared to DBS, considering the cost and the excessive period of hospital stay. However, I feel that the only way forward is, as you were discussing, as Dr. Shyam Sundar and as the other two of you were also discussing. So I think a little bit of discussion with the MHRB is important, because the sense of resistance, if it is lessened from their side, we will be able to work more and be more encouraged to provide this form of treatment for the benefits of the patients rather than withholding it. Because this treatment as such is meant for those who are not responding to all other modalities of treatment. So we should not hold this form of treatment for those who deserve it or who want it or who can afford it. So I think this is it. And I again thank you, Dr. Noor, Dr. Ashwath, Dr. Panir Selvan, and obviously our resource person, the main speaker, Dr. Shyam Sundar, for such a wonderful talk. And obviously a big thank you to all the participants for having wholeheartedly participated, asked questions, answered the questions also. So I think overall a big success. And I am really happy that I managed to join it and be there throughout. Thank you. Thank you. And wish Evolve many more success in the further weeks to come.
Thank you, sir. Thank you, sir.
Thank you, Dr. Sujit. Thank you, everyone, for inviting me. It was a very nice experience. Thank you.
Thank you, Dr. Our chairperson, Dr. Sujit. Actually, Sujit was contesting for our editor post in IPS. So he was traveling across India. So he was busy traveling. Once I met him, and I want our Evolve has to be, we want to show our Evolve program to West Bengal. When I invited him, immediately he was accepted. His busy schedule, because Sujit was accepted because we were coming after Delhi. He wanted to travel West Bengal. In between, he was take a break, and he was there in the Delhi airport and taking our program. Thank you, Dr. Sujit, for your kind for our consent to chair our meeting. And also thank Dr. Shyam Sundar for his wonderful presentations. Because of our practice, we come across a lot of cases with especially the OCD, with the resistant OCD, the patient not responding to medication, even CBT. Then we'll be more worried to manage the patients. We don't know what to do. So there are some options that in the NIMHANS, they are having some positive response of the surgical intervention, especially for OCDs, and also they have done for Tourette syndrome also they've done a surgery for one patients, and they showed some improvement. So I think that this neurosurgical intervention in psychiatric practice, spoke by Dr. Shyam Sundar, definitely it will be useful. And I thank my colleague Dr. Noor Hassan and Dr. Ashwath and all the participants and postgraduates for the active listening and participation in this program. The YouTube link is with eastwestpharma. Anybody want the link of this program, you can get it from eastwestpharma. So our next webinar, Evolve webinar date will be informed soon. My special thanks to the sponsor of this program, eastwestpharma. I conclude this session with the eastwestpharma vote of thanks.
Thank you so much, Doctor.
I request Dr. Panir sir to set up a DBS suit in this zone. It will be a great innovation, sir.
Yeah, the Shyam Sundar is there. With the help of Shyam Sundar, the guidance, I think in South we can plan it, especially in Tamil Nadu. We can have I think Shyam Sundar, I think that more people has to know about these surgical interventions. So you have to create a lot of awareness even among our psychiatrists. So we can have a program with in-person program with Dr. Shyam Sundar.
Sure.
Our Tamil Nadu IPS.
Sure.
Thank you so much, Doctor, for giving this opportunity to coordinate with our great psychiatrist speakers like this. And I'm thanking Dr. Panisalam sir to coordinate this wonderful session, and it will benefit it across India. Today, we have seen many participants from all parts of India, like Bihar, Delhi, and NIMHANS. Across India, we have seen, Doctor, especially the participants from AIMS, Delhi, and Jawaharlal Nehru Medical College students also participated today. So it shows our reach, our content, Doctor. So eastwestpharma is always dedicated to have such wonderful programs with great speakers like you. And I'm thanking today Dr. Shyam Sundar sir for giving a wonderful lecture for our benefit of our PGs, those who are coming regularly. Now, in this platform, I'm requesting Dr. Shruti, Dr. Muhammad Labita, and Dr. Rakshana kindly put your details in the chat box for handovering the certificate as well as the gift coupons to you, Doctor. And my cordial thanks to Dr. Nurul sir, Dr. Ashwath Babu sir for coordinating the wonderful program delivered in a beautiful way. Thank you so much, Doctor. Have a nice day.
Thank you. Thank you all.
Thank you.
Thank you.
Thank you.